I can hear you there too.
Oh, no.
Sit next to the heater, I'm freezing.
Okay.
Thank you very much.
So welcome everyone, I'm Dr. Singh. As you all come in, we're giving a few minutes for people to get in, and you should be seeing a shared slide that gives you information about how to register with Cloud CME so that you can get CME or internal medicine MOC credit at the end. Please remember you have to be registered with this before you mark attendance and try to get credit. So if you can look at that slide, please take care of that now as we wait for others to come in. Thank you.
Neeraj, you can hear me okay?
Yes.
I'm having a little hard time logging on. My camera is disabled also, by the way.
Oh,
All cameras are disabled, Dr. Bhalla.
All right, thank you.
just a quick thing. Do we know if we're able to specifically re-enable Dr. Bhalla's? Let me know if we can.
Dr. Bhalla, your camera is activated.
Thank you.
You're welcome.
So this is.
Good afternoon, everyone, and thank you so much for joining. I just wanted to start the presentation with a reminder on how to obtain CME credit, noting that this presentation is eligible for CME, or ABIM MOC credits. So with that, there are 3 ways to submit attendance. The first important step is that you must be registered with the University of Arizona Cloud CME platform. Once you have that account, you can text your attendance code for this session, which is 55175, to the number listed here. You can also set up an account through the mobile app and claim your credit there, as well as claiming that credit through the online attendee portal. So we will send out some directions after this presentation as well, but just wanted to note that to claim credits, you must have your attendance submitted within 24 hours of the presentation. With that, I will turn it over to Dr. Neeraj Singh and Dr. Tarun Bhalla to discuss applying the AHA ASA stroke guidelines in 2026. And again, thank you so much for joining today.
Welcome, everyone, and thank you very much. And thank you, Allison, for that introduction. I'll just also give a brief reminder that if you are with internal medicine, you're seeking maintenance and certification credits, MOC, in that same link where you complete your profile, you just have to enter your birth month and day and make sure to click yes when asked if you're claiming MOC points, and then select your board, which should be American Board of Internal Medicine. You'll need to enter your diplomat ID there as well. But again, if you select MOC and ABIM, American Board of Internal Medicine, you'll be prompted to enter your ID so you can claim MOC credits. So thank you, everyone, for joining us. I'm Dr. Neeraj Singh. I'm teleneurologist with Savara Health and also with privileges in Northwood Health in New York City. And I'm accompanied here by a neurointerventionalist at University of Rochester, Dr. Tarun Bhalla. Thank you very much for joining us. Today, we'll be going over some of the key updates in stroke guidelines as published by the American Heart Association and American Stroke Association in January 2026. But we'll also take a moment after some of the key guideline updates to go over how this is being implemented in real time at a comprehensive stroke center such as the system with University of Rochester. And Dr. Bhalla will give us some insights there as well. And we welcome your questions as well. As we go through these, you're welcome to enter questions in the chat, and we will try to accommodate them and include them as we go through. Okay? So without further ado, I'll just give a little introduction to the stroke guidelines. So just briefly, some disclosures. As I mentioned, I'm affiliated with Northwood Health and Savara Health. Dr. Bhalla is affiliated with University of Rochester Medicine, and also has had a previous consulting relationship with Stryker and Medtronic. But in this presentation, no brand name commercial products or services will be discussed. So just a brief overview and a recap of where we are now compared to before. When we think about acute stroke management prior to this year, keep in mind that the last major update in stroke guidelines by the AHA and ASA were published in 2018 with a supplement given in 2019.
Thank you.
And the major points from these previous updates was that TPA or alteplase as an IV thrombolytic agent for acute stroke was indicated within 4.5 hours of, or 4.5 hours of last known normal for all patients. Prior to that, there was a restriction of only up to 3 hours from last known normal for those over 80 years of age. Endovascular thrombectomy or EVT within 6 hours of last known normal was also indicated, but it was really mainly indicated for anterior circulation occlusions. That means we're looking at internal carotid arteries or the proximal segments of middle cerebral arteries, as well as a pre-stroke modified Rankin scale of 0 or 1. In other words, someone with very few deficits before and with an anterior circulation proximal occlusion and within 6 hours last known normal. Those limitations were there in order to determine someone's a good candidate for thrombectomy. Also, there were no guidelines for patients under age of 18, no recommendations for other things like mobile stroke units and how they may help in the logistics of stroke management. But since those guidelines, we've had the major pandemic with COVID-19. We've had increased use of telemedicine and mobile stroke units. We've had more clinical outcome information in pediatric stroke cases, which of course have lower incidence but still are present. And we've had some more research done and some more practice use of tenecteplase or TNK as an alternative IV thrombolytic agent to TPA or alteplase, as well as whether there's a role of other blood thinners and as well as how strict we need to be about glucose and blood pressure management in acute strokes. So with all this new information in the last few years, these have justified the publication of new guidelines this year. Some of the major guideline updates, I just want to first remind all of you that the full document, full 120 or so page document is available for free. It's a free PDF available at www.ahajournals.org. You can search 2026 guideline and you're looking for the article with chief authors Prabhakaran and Gonzalez. But even though it's a long document, even that has a good summary and table form at the beginning, so you can use that as a reference if you needed to keep that. But some of the key things that we'll be discussing today are the following 7 things. First, this time we have the first clear guidelines on pediatric stroke management. We have recommendations on how and when mobile stroke units can be used in place of conventional ambulances. Also, there's a recommendation for establishment of well-coordinated stroke systems of care to help with transport logistics to get stroke treatment accomplished as soon as possible. There's also an important extension of the allowed time window from last known normal for IV thrombolytic agents in specific situations. And then there's also an expanded eligibility for endovascular thrombectomy. So in other words, more patients under the current new guidelines can be candidates for the IV thrombolysis, TPA or TNK, as well as endovascular thrombectomy. Also, there's some clarification on whether and how to treat strokes if there are non-disabling deficits, or sometimes what we call minor strokes. And finally, there are updated recommendations on blood pressure control, glucose control, and whether to use other antithrombotic agents besides the TPA and TNK for thrombolytics. So we'll go over that in detail and address some questions related to those. So just first briefly, just to get this part clarified and done, pediatric stroke management. So in cases of suspected acute stroke in a patient under 18 years of age, again, prior to this year, there weren't clear guidelines. Now the recommendation is, in order to try to minimize radiation exposure, there's a preference in such patients for MRI brain and MR angiogram of head and neck, if available in an emergency setting within 25 minutes. If it's known that it won't be available in that time, then the recommendations go straight to emergent non-contrast CT brain and CT angiogram of the head and neck, similar to what we would do for an adult, that we go straight to those for an adult, not even waiting for MRI. Right now, there's enough information to say that IV TPA is safe for pediatric patients between 28 days of age and 18 years of age. The efficacy is still uncertain. So we know it's safe. We're not entirely sure how efficacious it is. Part of that is due to limited amount of data because it's not that common. And there is just not enough data to confirm whether tenecteplase or TNK is safe or efficacious. So right now, the recommendation in the guidelines is that IV TPA or alteplase can be used in these pediatric patients presenting with evidence of acute stroke. Endovascular thrombectomy is also now indicated in these pediatric patients if there is a large vessel occlusion or LVO present, as long as patient is age 6 or above, typically within 6 hours last known normal, but may be allowed up to 24 hours after last known normal if you have a perfusion study that shows a large penumbra or large area of hypoperfusion, suggesting a threatened but not completed stroke. It is, in other words, it's definitely safe from ages 6 and above, but only relatively safe even as young as 28 days, but you're looking to get a patient in that situation in a center where there are neurointerventionists with pediatric experience. So it's good to have these guidelines in place. Now there's not as much question about which image or which type of agent to use. But again, clearly more research needed, more data as the years go by, as we get more cases. So I just want to take a moment briefly to check with Dr. Bhalla. In your medical system with the University of Rochester system, I just want to confirm, do you even see many pediatric patients? Do you, when it comes to thrombectomy stage? And even if you don't, what are your thoughts about the fact that there are now for the first time just new clear guidelines for managing acute strokes in pediatric patients?
Yeah, thanks, Neeraj. So we are about 1,000-bed hospital on the adult side and probably about a 250-bed hospital on the pediatric side. So we have a standalone children's hospital. But even then, the incidence of stroke in this patient population is relatively low. I think it's great that they make the guidelines because it increases awareness of the disease. And that's what we've struggled, I think, with the most, at least in this patient population. At least in my system, one of the worst outcomes that people have are the patients that are already admitted and are having a stroke, not the one that shows up to my emergency room. And generally with kids, that's also the case. The other thing to keep in mind with the pediatric population is it's not going to be atherosclerotic disease, right? It's probably going to be a traumatic dissection or some sort of congenital issue or something else metabolic that's contributing to this and them having a stroke. So I think it's important to kind of keep all that in mind as we sort of think. So the more awareness that we can provide about this for the pediatric population, I think the better the patients are going to do.
Excellent, thank you. And we do have a question in the chat that's important. Karen Greenberg mentions one of the absolute contraindications for TPA or TNK is age under 18. So the question is, has AHA and American Stroke Association officially changed the indications and contraindications at this time? So the answer to that is yes, in the case of TPA. So again, I'll just go back. In the case of specifically TPA or alteplase, age under 18 is no longer a contraindication. As really technically the age under 28 days is the contraindication. It's just so 28 days to 18 years is considered safe to be able to administer it. We'll go a little bit later into whether we give it if there are non-disabling deficits, a low NIHSS with non-disabling deficits. That's another question. But yeah, just broadly speaking, they're less than 18 years of age is now no longer an absolute contraindication as long as we're dealing with TPA and not meeting other contraindications for getting this medication. Good. Thank you for that question. Okay. So we'll go into some other important points from the stroke guidelines. Mobile stroke units. So where available, the recommendations now is that mobile stroke units are preferred over conventional ambulances to transfer acute stroke patients who are neurointervention candidates, especially when the hospital center where interventions available is far away. Typically, we're looking at a minimum of 25-minute duration of drive. Typically, these mobile stroke units will contain the basic things that even a conventional ambulance would contain. So ability to check vital signs, ability to check point of care labs like glucose, INR, creatinine, potentially even check certain basic labs like a BMP. What's additionally available in these typically is that you'll have a portable CT scanner, so you can get a non-contrast CT scan of the head done while the patient's en route, be able to identify if there's a bleed or if there's not. A major thing to distinguish before we can continue with our treatment process. Typically, this is equipped with a telehealth availability with a teleneurologist. And often these actually have IV medications available so that they can be administered if indicated with the information we have. So IV, TPA, or TNK typically is available. IV antihypertensives may be available to help bring blood pressure within parameters if that's the only absolute contraindication for getting TPA or TNK, and then even such medications as vitamin K or PCC if we're dealing with an intracranial bleed. So in other words, the ability to initiate treatment is there, even if the patient's far away from a center where they can get further treatment. So Dr. Bhalla, I want to ask you a little bit if you can go into more information about your facility's stroke program, in particular. How long have you had your system has a mobile stroke unit system, and what has your experience been with starting and growing that system at your facility?
Yeah, thanks. So we've been very fortunate up here in Rochester. We started our mobile stroke unit program in 2018. So we've been active now for about 8 years. In fact, we just got our second unit delivered last week, and we're about to put that into play. And there are many challenges to implementing this. There needs to be a partnership between local EMS and both in the short-term area around the hospital, but also sort of the moderate distance. And everybody sort of needs to be on board and commit to the philosophy of the value that a mobile stroke unit brings. And sometimes that can be a challenge because EMS is dealing with their own issues all the time. And I always have to remind myself that, stroke is about 1% to 2% of what EMS deals with, and 98% of what they deal with is non-stroke related. So they've got their own pressures that they're dealing with, just as we have our priorities around stroke. But the benefits are clearly obvious. I mean, I think what Jim Garata and his group has shown with the best MSU study, we've replicated up here with our data, is we can shave off significant amount of time going and treating patients right in the field. But the cost can be, significant. We spend about $500,000 a year operationalizing this. So I think not every system is going to be able to do that. We've been very fortunate from the support from the hospital that we've gotten to keep this in place.
Can you give us a sense of the kind of geographic range that's served by your mobile stroke unit? It sounds like for all this time it's been mainly one and only recently now two. How large an area are you covering with this?
Yeah, so we can cover almost the entire county primarily with our unit. Just from a catchment area standpoint, one unit is probably enough for roughly about 1 million people that you're serving, and that can either be concentrated, but the farther out you get, the further spread out sort of, that geography becomes. And then if we draw sort of a circle around, say about 35 minutes of driving distance, and we aren't Los Angeles, we're not New York, so 30 to 35 minutes can take us actually pretty far from where we are. There's probably another 30 or 35-minute circle that you can draw around that in which we do rendezvous. So if somebody on the outside of that circle is having a stroke, we are partnered with all the participating EMS agencies where they drive to us while we drive to them, meet in the middle, and sort of at a Home Depot parking lot or even a Walmart parking lot, we'll do a transfer of care. And we've given IV thrombolysis there for people who might be just at teetering at the 4.5 hour window.
Very good, thank you. And I just want to confirm the description I made of the kinds of things that are in a mobile stroke unit that's additional beyond conventional ambulance, like a telehealth video system, like the portable scanner, even like the various IV medications. Is that consistent with what you have there? Are there some limitations what's available in yours?
No, it is very consistent. We also have CT angiography, which we've been doing since the beginning. So we can do CT angiography of the head. The scanner itself doesn't allow us to go deep into the neck, but we can get carotids at the skull base and the verts at the skull base.
Excellent, very good, thank you. And again, to the audience, feel free to ask or enter the chat any questions related to that. And I'll make sure to come back to those. Let's go into some additional recommendations in the guidelines. So this is actually a bit related, just talking about stroke systems of care. So, right now we're talking about the guidelines on the way to the hospital. Then we're going to talk about what happens when you're actually giving the treatment. So it just emphasizes it's important to establish agreements and protocols ahead of time to prioritize inter-hospital transfers for stroke patients who need higher level of care beyond what's available where they're at. And in areas where there are known to be well-coordinated stroke systems of care, or SSOC, in that case, when the decision on the EMS side is where to take a patient, there really isn't an advantage to going to a distant comprehensive stroke center. We're talking about having to go an extra 45 to 60-minute drive over a local primary stroke center. However, it does also point out that if it's known that a certain area, community, or county has poor stroke system of care coordination, then in those cases, there should be consideration to transport to a distant comprehensive stroke center, that there may be delays in getting a person from the primary stroke center immediate care to the comprehensive stroke center if they need that. But also there's a recommendation that these are communities that are ripe for the benefit of mobile stroke units to be implemented there. So can I ask you also, Dr. Bhalla, a little bit about how the inter-hospital transfers and the systems of care for stroke work for your hospital and in your county and community?
Yeah, that's a great question. And, I think every community is going to be different, but let me just sort of describe the geography a little bit about where we are. So we are at the northern end of New York, just south of Lake Ontario. It's a fairly moderate-sized city, which goes from urban to rural very, very quickly. So there's a large sort of change in geography that happens. The other thing that we are affected by up here in the north is we are affected by weather. So about 4 months out of the year, we don't really have great access to helicopters flying, either due to cloud cover or due to snow. So all that sort of impacts, how we coordinate our stroke systems of care, because we cover all the way from Rochester down to the northern border of Pennsylvania. If you took a straight shot down from Rochester, and we go all the way east to about Cooperstown. So it's a large geography and a very varied geography and population that we're trying to cover. And the goal that we have really is to minimize our door in, door out times at these smaller hospitals. There really is not a comprehensive or an academic center in that geography that we described. So we need everything to come to us and come to us relatively quickly. So we've had to partner very, very closely with a lot of the flight teams in and around the area. And we've developed systems that allow the flight teams to get flight hours that they need And we've tried not to be prescriptive about it, especially in the rural hospitals, because a lot of the resources like advanced imaging don't exist there. And there are staffing challenges at these very small hospitals.
Excellent, thank you. We do have a question in the chat that's also relevant to this. Can you describe in the mobile stroke units that are used in your system, what personnel are there? What kind of extra training may a personnel on mobile stroke unit need compared with on a conventional ambulance? And do you have a sense of the annual volume? You mentioned what the catchment area is, but what's a typical annual volume of people who actually end up being served by the mobile stroke units for your system?
Yeah, great questions. So there's different models that people have adapted around the country. What's worked for us is to have a 4-person team. So we have a driver, an EMT driver, we have a paramedic, we have a critical care nurse, and then we have a CT tech. Our CT tech and the critical care nurse are employees of the hospital. The paramedic and the driver are employees of the EMS service that we contract with. So what I wanted to sort of think about is I didn't want our hospital to be in the EMS business, just as the EMS team doesn't want to be in the hospital business. So we let them do what they do best, and we do what we do best. But it's really been a marriage of skills from that standpoint.
Great, thank you. And I also do want to ask
and the question about the annual volume. So
volume, yes.
we on annual probably do about 70 to 80 thrombolytic cases on the mobile stroke unit. So, it's not a small volume with respect to that. By comparison, our ER does, maybe about 110, 120 or so.
Great. So it's almost rivaling what the ER does in terms of volume per year, it sounds like. Yeah. It just from what you've observed in your own system as far as inter-hospital transfer go from the primary source centers of rural to the main one, or even others that you've observed elsewhere, do you see any opportunities to improve the efficiencies, to improve some of that? Maybe that others on the call could benefit from?
Yeah, I mean, I think the pandemic has really devastated EMS capacity in rural communities. So one of the things that is a strong barrier to patients coming to us, even though everything is put into place, is, for example, the availability of an ambulance that the local community can find to take them a long distance. What that does is actually two things. It one takes that ambulance out of service from that local community for whatever they might need. And then two, it's a two-way street. They have to come to us maybe 2.5 hours, but then they also have to drive back. So what I think we need is probably a better inter-facility transport system that connects smaller rural hospitals that aren't looking to take business away, say, from local EMS communities, but are only there for hospital-to-hospital transfers. And certainly, I think New York State can do a better job of that.
Great, thank you. Very insightful. Thanks. We'll look into some of the other guidelines as well. I'll just go to the next one here. So this is an important one, extension of the IV thrombolytic window. So just as a reminder, IV thrombolysis means with TPA or now TNK, it's indicated for all adult patients within 4.5 hours of last known normal. That's as of the 2018-2019 guidelines. And then since then we've had results that have come from the Extend IA TNK trial that actually showed that TNK was superior to the TPA for functional outcomes in stroke patients. But then we've also had the ACT trial, the ACT trial from 2022, and the TRACE-2 trial 2023 that just showed that TNK was non-inferior, so not worse, but non-inferior to TPA. Therefore, now in the 2026 guidelines, it's kind of clarified and confirmed that tenecteplase is considered a suitable alternative to alteplase TPA. That tenecteplase is now officially considered non-inferior. That's the majority of the research outcomes. So that's considered the standard of the guideline. And so this can be used instead of TPA. In many cases, as you may recall, TNK ends up being TNK in general is more efficient in that it's an immediate administration, non-administration that has to be run over an hour. So in many locations, that ends up being very helpful from a logistical standpoint and getting treatment done soon and getting a patient in the appropriate disposition after that. So that's why in the last few years, especially since the results from 2022 and 2023, you've seen more hospital systems start to employ tenecteplase TNK instead of in place of alteplase TPA. Now, as we get to the new guidelines, IV thrombolysis is now indicated for all patients, not just for within 4.5 hours, but if you have imaging evidence, such as a CT perfusion scan of the head, which shows salvageable ischemic penumbra, or essentially an area of threatened stroke but not completed stroke, and it is within 9 hours from last known normal, or 9 hours from the midpoint of sleep if someone is waking up with stroke symptoms, it is now considered relatively safe and appropriate to give IV thrombolysis in this time range. Some other information, the Extend trial, which resulted in 2019. So the results came just after these updates to the previous guidelines. It did test for IV TPA versus placebo within 4.5 hours of last known normal with this penumbra perfusion imaging showing evidence of penumbra. It showed that people were more likely to achieve modified Rankin scale of 0 to 1, that means close to normal exam of functional outcome than placebo, if TPA was given in this 4.5 to 9 hour window, and that there was no significant difference in the 90-day mortality. So more likely to get better functional outcome, no significant increase in mortality. If you look at the actual absolute numbers, there was a numerical increase, but statistically it was not considered significantly greater. Now, what's notable is that symptomatic intracranial hemorrhage was seen in 6.2% of patients who got TPA versus 0.9% who got the placebo. So there is a higher absolute risk. But then recall that previous trials that have looked at TPA within the normal, what we've considered the typical guideline of 4.5 hours from last known normal, have shown that the risk of ICH or intracranial hemorrhage can be within 6.4% of a range. That's within 3 hours, according to the NINDS trial, and then can be as high as 5 to 6% within 4.5 hours in the ECAS-3 trial. I bring this up because, in other words, the percentage of risk, while it's higher than placebo, if giving TPA in the 4.5 to 9 hour range, is about the same range of percentage risk as you saw from the previous trials that justified the extension of the window to 4.5 hours. And then a lot of these results have been corroborated by other studies. You've had the Wake Up trial in 2018 that actually included MRI DWI studies in wake up strokes instead of perfusion imaging to identify stroke. And then there was another ECAS-4 Extend trial that looked at both MRI DWI scans and the CT perfusion scans. So in summary, there's been enough information between the last guideline publication and this one to now say that it should be safe to give IV thrombolysis within 9 hours from last normal if you have this additional imaging showing or proving that there is actually a large area of threatened but not completed stroke. So this is a big change, and I know it can be a big leap for certain systems to be able to adopt it or to consider it. So I want to ask you, Dr. Bhalla, in your particular hospital system, is this something you have started, this guideline you've started to update and implement a longer time window? If so, how has it gone? And if not, what are some of the concerns or limitations in your system or in your discussions?
So we're doing this just very, very selectively only at the main campus, right? Because we have access to all the imaging and we're able to lay eyes, hands, and ears on the patient and really talk to the family in person for most of the time about sort of what's going on. At our most of our region and in our smaller hospitals that we serve, we have not done this simply because of the fact that most of us sort of think that this might be going out on a limb and you want to sort of do this as safely as possible and to really have tight parameters around this and to do it in sort of a person-controlled manner. I think what's sort of needed on the extended time window is probably a bona fide real-world registry, because what you get in a clinical trial is going to be very different than what happens in the real world. And we see that no matter what the trial is sort of being done in. And I think over time, what we're going to see is that symptomatic intracerebral hemorrhage rate probably will creep a little bit higher in the real world. These patients that are enrolled in trials, they get all the bells and whistles and all the protections that a clinical trial sort of demands. And that doesn't happen in the real world with the resources that are really available at some of the smaller centers. So we've tried to be very careful and walk a very fine line. Is, in our center where all the imaging is available 24/7 and we can get it in a timely manner, we will definitely consider it in the right patient. But in the smaller centers we serve, we want to be very, very careful to do no harm.
Excellent. Yeah, and I think you bring up a good point. This addresses one of the questions that came up in the chat, that if a community hospital does not have access to CT or MR perfusion studies, is it safe to give to selected place beyond the 4.5 hour window? So I think you make a good point. The trials upon and the studies upon which the guideline updates are based were all done in comprehensive stroke centers where you can have these protections, have these protocols. And so they have these imaging readily available. So therefore, and the thing is, most rural hospitals, even many under-resourced urban hospitals, don't have access to that kind of imaging. So right now, the guideline is that if you don't have access or don't have that information from CT or MR perfusion, then you cannot go by the extended time window. You have to stick with the original 4.5-hour window, which I'll go back to that, which was the first line, the 2018-2019 guideline. In other words, that guideline still holds true unless you have additional information at the point. It may change your decision process. If you're in a rural location or in any location that does not have perfusion studies, earlier may have thought, oh, we're at the end of the time window, say 4.5 hours. So there's no point in rushing a transfer somewhere else where they might have access to perfusion. Now you might entertain and be able to say, actually, we still have a chance. There may be a chance, especially if there's a high disabling stroke, high NIHSS score, to say there actually is this extended time window if we can get this person to a place that has it in that time range. So we can actually, it does make sense now to make the arrangements to transfer a patient to that comprehensive center with access to that. It also may influence more hospital centers who don't have access to perfusion studies to now have them, because now you have the ability to do something with that information over a longer period of time based on the current guidelines. So that would be the answer to that answer. Right now, no, you can't do that if you don't have perfusion imaging. But your medical center might look into getting it, or at least look into transferring it, even with a longer time window range. Okay. And then Dr. Whittingham does bring up a good point. Yes, the typical risk range we say is 3 to 6% overall for intracranial hemorrhage after giving an IV thrombolytic within 4.5 hours. That's TPA or TNK. So again, going back to the study, the symptomatic ICH in TPA up to 9 hours or 4.5 to 9 hours is 6.2%. So it's at the higher end, or really at the high end of that risk range. So that's something to keep in mind. But it rounds to 6. It's still in that general range. It's not significantly higher than the range that we were already looking at. So someone's asking if every rural hospital has CT perfusion, we still say they should be transferred to larger hospital if those rural hospitals don't have 24/7 MRI capabilities. So again, the guidelines indicate that you don't necessarily need the MRI to make the decision. Some of the studies did use MRI, DWI imaging to help identify presence of stroke and wake-up strokes. But specifically, if perfusion study is available, and that shows evidence of penumbra, that should be enough to be able to make this emergent decision about an IV thrombolytic. So you don't necessarily need to you don't necessarily need to get the urgent MRI there. I think the question still is up in the air as to whether you will need to transfer them for MRI or not. But I think I can say for sure that probably doesn't need to be done on an emergent basis. At least you've gotten the emergent treatment done. Do you have any thoughts about that, Dr. Bhalla, that if perfusion's available, the need to transfer MRI?
I think if you've got perfusion available and you can get a pretty good sense of how big the infarct is, and again, it's about the quality of the imaging. So if your rural hospital still has only an 8-slice CT scanner and the quality of the imaging is pretty poor, that's going to be very different than a 64-slice CT at a major center. So I think the amount of hypodensity you might or might not see will vary based on those two quality images. When you're making a decision, it's about the clinical exam and a combination of the imaging. This is why I do think that it makes sense that if your imaging quality is high, you can make a decision, but then you probably ought to transfer the patient after that.
Thank you. Someone asked, besides time frame, what other inclusion criteria should be considered for the extended time window? Any minimum NIHs or MRS? We'll get to a slide about non-disabling deficits in a moment, but in brief, the key thing is if someone is having acute stroke symptoms and if there are disabling deficits, that should be sufficient to consider someone for the extended time window, as long as you have the other criteria met, such as the perfusion imaging that shows a large penumbra. So just again, it's about the exam, about the severity of the stroke. Someone asked, what were the guidelines in 2018 and 2019 for wake-up strokes? From what I understand, essentially none. There were no clear guidelines about that. It was just stick to the 4.5 hours since last seen normal. So many people were ruled out of that because that would have been too soon a time after the patient's bedtime. What I can tell you is that the recommendation of 9 hours from the midpoint of sleep, there was a discussion from what I've learned from the International Stroke Council meeting, descriptions about this. There was no study actually done saying let's test the midpoint. It's just that there was a determination that using the bedtime was probably too conservative to use that as the last normal time, and using the wake up time was probably too liberal or allowing too much. And so that on a population basis, on average, choosing a midpoint time of when someone slept and then woke up with stroke-like symptoms would be the best compromise on a population basis to determine when the most likely, on average, last seen normal time is. I leave it to you and your individual facilities to decide if that was a right decision, but that was the determination based on that, just given a lot of data being available showing that when perfusion study is available and showing a large penumbra, it is better to give treatment than not. So that's where this 9 hours from midpoint of sleep is. It means a little more work for us when you get the history, because now it's not enough for us to ask and confirm what was the bedtime or was sleep time, but we have to try to confirm when is the wake up time and then quickly calculate what the midpoint of that would be. Any thoughts you have that, Dr. Bhalla, about giving a thrombolytic after for a wake up stroke? Your thoughts about using a midpoint of sleep as the start time, so to speak?
Yeah, I think what I find, at least in those acute settings, is that the history always changes. And I'm more sort of leaning towards what I find on imaging. What's the size of the infarct? What's the perfusion telling me? What's the status of the collaterals in terms of making a decision?
Okay, very good. Thanks. I'll go for a moment to the next slide. Just remind us, if the question did come up and I've even forgotten, just remind us, what was the typical cost for the mobile stroke unit? How much does your institution invest in keeping that going?
Yeah, so the capital cost is roughly somewhere between 1.3 to 1.5 million dollars now for the initial outlay for one unit. Half of that cost actually is the CT scanner itself, and the rest of it is the ambulance and all the bells and whistles that go inside it. And then, at least our cost in the staffing model that we have is about $500,000 a year.
Very good. Thank you. So a large capital cost, original cost, but then some ongoing costs for the maintenance. Very
Yeah, and our capital cost was raised by philanthropy and by foundation funding, but the operational cost for us is borne by the hospital.
So thank you. I'll go into the next set of important guidelines. So there's a lot of information here, but I'll try to go through this step by step so it's clear. And Dr. Bell, you may have some perspectives on this. So expanded eligibility now for endovascular thrombectomy. So I wanted to just briefly remind you, without having to go through the full detail about it, that we have this score called the ASPECT score, the Alberta Stroke Program Early CT score. Essentially divides the middle cerebral artery territory into 10 regions. 10 is a good score, top score, and then you subtract a point for every region affected by an infarct as seen on a non-conscious CT head. There's an alternative version of that known as a PC aspects, which divides the posterior circulation on one side into 10 regions to look for posterior circulation strokes. So I bring this up because under the previous 2018 to 2019 guidelines, endovascular thrombectomy was indicated if someone had a proximal anterior circulation occlusion, that means internal carotid artery or first segment, M1 segment of the middle cerebral artery, within 6 hours of last seen normal, if their NIHSS score, so if they have disabling deficits and their NIHSS score is at least 6, and their pre-stroke modified Rankin scale was 0 to 1, basically with 0 to no deficits, and also they had aspects of anywhere between 3 and 10 of a score. So you had to meet all these criteria to technically say that you were qualified. That means there's clearly by exam and by evaluation of the scan that a large area in the anterior circulation is affected. What the current guidelines say is that there are other possibilities, other essentially pathways to be able to determine if you're eligible. So it's still indicated within 6 hours of last seen normal. if your NIHS is at least 6 with disabling deficits. But now it's also allowed if your pre-stroke modified Rankin scale was not that perfect. It may have been 2, but your aspect score is still high, 6 or greater. Or if your pre-stroke modified Rankin score was low, but you're a relatively young age, being under 80, and no significant mass effect present from the imaging. And finally, thrombectomy is still also indicated within 24 hours if you have a high enough NIHSS, at least 6 with disabling deficits, and you're having a baseline modified Rankin scale that was normal, 0 to 1, but you have an aspect score that is as severe as 3 to 5, and also you're young enough under 80. So you don't necessarily at the moment need to remember every single possibility, but it's important for someone making the decision in the urgent setting, all the different possibilities. But it's good to see that there are different pathways to become eligible for intervention with thrombectomy. Finally, I just want to point out also that now there are for the first time guidelines on whether someone's indicated for thrombectomy for posterior circulation, and specifically endovascular thrombectomy is indicated within 24 hours of lasting normal, not just 6 hours. If there's a basal artery large vessel occlusion, NIHS is high, at least 10. Oh, excuse me, I missed that. I'll put that in. But pre-stroke modified Rankin scale starting low at 0 to 1, but also a PC aspect score of at least 6. So now there's some guidelines or direction for posterior circulation basal artery occlusions as well. So I want to ask you, Dr. Bhalla, about whether your system has either from these guidelines or even from before expanded eligibility for thrombectomy, and have you even seen more patients being referred for thrombectomy lately since these guidelines were published?
Yeah, we had expanded our guidelines even well before these guidelines were published. And we've seen our volume sort of grow, whether you're talking about expanded window, whether you're talking about large core infarct, or whether you're talking about sort of MEVO-DEVO type thrombectomies. So, I think when you look at the power of mechanical thrombectomy, for example, if you look at STEMI, right? STEMI's number needed to treat for having a good outcome is roughly marginalized about 14. Thrombectomy is so much more powerful than even treatment for STEMI, where the number needed to treat is in the low single digits, depending on which subgroup analysis you look at. So, there has to be a good reason for me not to do a thrombectomy with a vessel occluded and a disabling deficit in a patient. You have to sort of convince me that a patient coming to my ER does not need one with a vessel that's occluded rather than need one. So I think the whole paradigm, at least in our system, has shifted.
Excellent. Thank you. Can I ask your thoughts about this? Again, the guidelines, a lot of these expanded eligibility pathways still say, okay, safe, but as long as you're under the age of 80. So can you tell me a little bit about your experience of any more elderly patients, 80 or above, and if you've noticed some other safety concerns present when someone is of that age?
Yeah, absolutely. I think that's a great question. And I want to also come back to the aspect 0 to 2, because we talked a little bit about the low we talked a bit about the
I think we
Dr.
maybe
Neeraj, why don't you go ahead, Dr. Singh, go
Yeah.
ahead and keep
Yeah.
going.
Yeah,
Come back up.
just have a connection issue there, but I will continue with some of the rest of the guidelines, and we'll have Dr. Bhalla assist us with that answer after we get back. Feel free to still ask your question in the chat. Okay. Give us one moment.
Can you hear me okay?
So,
For some reason I
yeah,
got
Dr.
kicked
Bhalla,
off
we can
the,
hear you now. Yeah.
So I was
Yes.
going to say is I want to circle back to the large core infarct, because we talked a little bit about the low aspects of treatment. And we're not routinely doing anything in the really low aspect range, and we'll sort of be very, very selective about it. We don't hold age as really a criteria. I think it's about having a conversation with the family and figuring out what the priorities of their loved one were, and really getting a sense of their rehab potential. I think there are going to be 85-year-olds who, if they're able to get back out and get back into rehab, are going to do remarkably well. And then there are going to be people who have all sorts of systemic disease that this stroke is really going to be disabling and aren't going to have a lot of rehab potential. And we really got to have an honest conversation with the family to figure out what their loved one could have wanted. So I think that's an important piece that sometimes gets left out of the guidelines.
Thank you. And I think you bring up an important point too. So the fact that even in general, you have your institution has expanded eligibility even before these were published, that a lot of these guidelines are based on research that has been done in the interim since the previous guidelines, a lot of real world data about how certain institutions are already forging ahead with trying to expand eligibility or availability of certain treatments. So guidelines in some cases are following what's some of the leaders in the field are doing. So it's almost like it's reflecting where we were at maybe couple of years ago, and then the next time we have guidelines out, it's probably going to reflect where we're at in these next couple of years, especially when these guidelines are published kind of every 5 to 7 years apart, it seems.
I think
Thank
you're exactly right. And in coming back to the guideline stated time window for a basilar artery large vessel occlusion, we don't really sort of subscribe to a timeline. I mean, with respect to that, as we all sort of appreciate, I think the biology and the window for the brainstem is probably very different than the cortex. So what we'll do in our center is we'll bring these patients in, get a quick MR, get a sense of the diffusion, and really correlate that with the exam and try and figure out if they would benefit. And again, we all know what the natural history of this is, right? If we don't get it open, these patients are going to die. And they might do okay if we do get it open. So again, I think it's the surgical sort of mentality has shifted around a lot of this. Is you've got to give me a pretty good reason to not do this, rather than the other way around, is having to prove to me that this is worth opening.
Very good. Thank you. I'll talk a little bit now on the converse side when we're dealing with non-disabling deficits. So we have some guidelines now in 2026 that say that when patients have non-disabling deficits with their stroke and their NIHS score is at most 5, that means we're dealing with a minor ischemic stroke or maybe even technically at that point a transient ischemic attack, then there's actually no benefit of giving IV thrombolytics, TP or TNK, within 24 hours. We're talking about, as examples, pure sensory deficit, a mild aphasia or dysarthria, even like an error in vision, like a counting error, but we're not talking about full motor deficit. We're not talking about unintelligible speech. We're not talking about complete or even partial vision loss. When we're talking about these mild symptoms, it's been found that the risks actually outweigh the benefits of giving IV thrombolytics, that instead it's reasonable to just give dual antiplatelets for at least 21 days, maybe longer, depending on the severity of cardiovascular disease that the patient may have, and thereafter single antiplatelet therapy. And that's been supported by various trials, such as the CHANCE, POINT, Thales, and Aramis trials over the past few years. Can I just confirm with you, Dr. Bhalla, have you had cases or even considered thrombectomies for patients where there is evidence of an occlusion, maybe large or medium vessel, but the deficits are non-disabling?
Yeah, I think that's a very difficult needle to thread sometimes, right? Because how do you really define non-disabling? And I also wonder at times whether the simple modified ranking scale that every trial under the sun has used, can we really distill down what it means to be a human being and have a non-disabling deficit into a 5 or 6 point scale? We can probably extend that even to the NIH stroke scale. So, and what's non-disabling right now in the present moment, what we think for that particular patient, I'm not just talking about sort of, numbness, right? That could be disabling depending on what you do for a living. For example, I had a surgeon who had a stroke, and fortunately, all he had left was finger numbness. But to that surgeon, that finger numbness is disabling, right? Because that means that he may not be able to be at the prime time of his skill that he trained years and years to do. So I think in our center again is we know that even in patients who have large vessel occlusion and let's say a low NIH stroke scale, there's plenty of data in the literature that says that for most of those patients, those collaterals will actually wind up failing at some point, right? And we have to be really, really careful about evaluating those patients. What does a stroke look like? Is it fluctuating? There's a lot of talk about keeping patients flat and giving them IV fluids. Well, you can't really discharge a patient when they're flat. You got to sort of eventually at some point stand them up and figure this out. Also, if you have, let's say, an 85-year-old patient who has tremendous amount of heart disease, and it's taking a blood pressure of 190 systolic and a MAP of 120 to keep their symptoms at bay. Well, how long do we really think that that's going to continue for that particular patient? And their stroke right now is non-disabling, but that's not a tenable situation, right? So I think there the care really has to be individualized to the patient, and we can't paint with a broad brushstroke. But most of those patients, the collaterals will fail at some point.
So thank you. And this relates to a comment in the chat by Dr. Whittingham that some important questions to ask in those situations, to check with the patient and observer, have the symptoms been fluctuating? If so, what is the worst exam? What are the worst combination of symptoms during the fluctuations? And then also keeping in mind the potential, the concern for failure of collaterals. These all will tie into the decision process. And again, having a clear discussion with the patient or whoever who's with them, who's taking care of them, making decisions for them about the risks and benefits of proceeding with a procedure like thrombectomy is going to be important. Very good, thank you. And then some other considerations about other systems management. So it's been found based on recent research that after IV thrombolytic administration, there's no benefit for strict systolic blood pressure control under 140, as opposed to keeping it permissive up to 180 within 24 hours of administration. And also after successful endovascular thrombectomy, there's also no benefit in strictly controlling the blood pressure, the systolic one under 140, as opposed to keeping it up to 180, even for a period of up to 72 hours. Furthermore, in checking about glucose management, serum glucose management with IV insulin, it's been found that having within the first 72 hours of an acute ischemic stroke, trying to achieve a serum glucose in a so-called normal or control range of 80 to 130 is actually more likely to increase risks of hypoglycemic episodes without improving 3-month functional outcomes. So there's actually in other words, there's a sense of allowing a permissive hyperglycemia within the first 72 hours of an acute ischemic stroke. There's also been some research looking into other antithrombotic agents to see if they can or should be given alongside a thrombolytic or thrombectomy procedure because they have worked for coronary interventions in an myocardial infarction. So argatroban and eptifibatide, I think I pronounced it right, has been studied after giving IV thrombolytic agents, but has been found to have no benefit for stroke. Tirofiban has also been administered in the study before endovascular thrombectomy, but again, no benefit. So right now we're still stuck with the classic, the TPA or now TNK for IV thrombolytics, and then endovascular thrombectomy without additional antithrombotic agents. Lastly, there's been a study of IV glibenclamide, or this is an alternative version of glyburide, to see if there's a role to reduce cerebral edema after large acute infarct, but not found to be beneficial. So a lot of important negatives just to make sure we're allowing permissive hypertension, permissive even hyperglycemia, and not adding extra agents that don't seem to help in terms of blood thinners or reducing edema. I just want to check with you, Dr. Bhalla, if you have observed any complications from any aggressive blood pressure or glucose control after IV thrombolysis or thrombectomy in some of your patients.
Yeah, I think what time has sort of taught us is that we can't be too aggressive about this, right? There's a period of sort of the loss of autoregulation that happens in and around the reperfusion window as blood is restored to that vascular bed. And it used to be that we used to be sort of relatively aggressive, making sure we get the blood pressure down. And I think time has taught us that there is probably harm with that. So we let the blood pressure ride to about a high of 180 systolic with setting a floor of about 100. We certainly don't want to press anybody that sort of drops down to like 95 or 100 or anything like that. So as long as they're in an ICU window and we're using common sense to treat these patients, I think that's probably the reasonable way forward.
And I'm just curious, have you or any colleagues been involved in any studies that involve trying to look at other antithrombotic agents, if they're helpful or not? And if so, have you seen any benefit or no benefit from those?
We've not been involved in any of the trials. Generally, I, as an interventionalist, whenever I'll sort of look and think about some of the other antithrombotics, really is going to be in and around. Let's say if there's a severe carotid stenosis proximal in the neck, as I have to go up and do a thrombectomy. I will do everything I can to actually not stent in the acute setting. I know there's a lot of sort of varied opinions out there just because I don't know how big that stroke is going to be. And I don't want to commit that patient to a P2Y12 receptor antagonist at that time. So something like a Berlinta or anything like that, I'll wait until I have post-op imaging and then figure out whether that stent needs to be dropped. And in the meantime, I'll give them just an angioplasty and then try and start them on essentially an aspirin until we can get the imaging done to figure out revascularization.
Great, thank you. Dr. Winningham in the chat pointed out that she's seen cases where integralin has been used in some cases after TNK for cases that can wait for stenting. That's something to consider to look into. It's probably something still being studied, but the guidelines haven't addressed that as yet. So I want to just summarize for everyone that with these new 2026 guidelines, the focus of stroke treatment is essentially changes from a strict time since last known normal to just evaluating the tissue at risk and using both the exam, but especially imaging such as perfusion imaging to help identify how much tissue is at risk, how much is salvageable. There's been an increased focus on improving logistics for stroke care, so those stroke systems of care, inter-hospital transfers, and presence of mobile stroke units. There's some clear guidelines for pediatric stroke management and clear recommendations on other related systems management like blood pressure, glucose, and in this case, the lack of evidence for other antithrombotic use. But again, when it comes to each hospital system, it's important to decide if and when to adopt these guidelines, if you have the right access to the resources. So especially with the extended time window, having access to things like CT perfusion or MR perfusion, and even having a system like a neuro ICU or at least a medical ICU with experienced professionals who can handle patients after these interventional treatments. So it's important. It's always important for us to be aware of the changes coming with the guidelines, but also be aware that, more changes may come. Maybe there'll be even more extended time window, even more recommendations on the effectiveness of things like mobile stroke units. So we look forward to the further things that come along. Just reaching out, please feel free to enter in the chat if there are any other questions. That's my email address, Neeraj, neeraj@savara.com. And I just want to go back to the very first slide also, just remind you of the instructions on how to obtain your CME or MOC credit in case you have not got to see that yet. So we'll leave that up for a moment so you get that information. Again, Dr. Bhalla, I want to thank you for taking the time to describe how these guidelines are being implemented in your system, and I'm sure this will help guide and influence us all in our respective hospital systems. Thank you.
My pleasure, Neeraj. Thanks for having me.
Thank you, Dr.
Thanks.
Bhalla. Thank you, Dr. Singh. As always, you guys did a fantastic job. Thank you, everybody, for attending. If there's any other questions, you can reach out to either Dr. Singh or myself here at Savara. Thank you, everybody.
Thanks. Wow. I'm just gonna stay on like Amanda and Annie for a minute with the shared slide, and then I'll stop sharing in a minute. Thanks.
Yeah.
I'll actually use this time to enter my own CME.
That's what I'm doing too.